I was out at a progress meeting, felt a bit dizzy, got up and collapsed in the place and was taken off to hospital. The brain goes dead, everything goes dead, all you know is you can't stand up. I've had shortage of breath and couldn't walk for a very long way without sort of having to stop and get my breath back again.
So aortic stenosis is a condition where the aortic valve, which is the main outflow valve of the heart, narrows. That restricts the amount of oxygen the body can get, and patients get breathless during exertion. When aortic stenosis becomes symptomatic, when it's preventing you exercising, the data suggests that for most patients their lifespan may be as short as 18 months to 2 years. The great news is that once we've treated the patient, their mortality, their risk of dying, goes back almost to what it was before. So although there is a risk with the procedure, that's all the risk there is pretty much, and you can then expect to have, you know, a healthy life thereafter.
The problem, as I understood it, was that it was my discharge valve from the heart, and it was a discharge valve that wasn't working properly.
So the first test we would do is an echocardiogram, and an echocardiogram looks at the heart and the heart muscle and obviously the valve and makes an assessment of how narrow that valve is. Once we've decided that valve is narrow enough to need treatment, we then need to decide how can we best do it safely. So we need some pictures, usually using a CT scan of the leg arteries, and we also need to see what the heart arteries are like.
The plaster receivers all over you, and then it asks you to do small, not significant manoeuvres, and they just watch how your heart's behaving with it.
When we have all the information, we sit down with an expert team and make a decision about whether we can get these devices in, whether we think the patient's likely to benefit, or whether an alternative therapy might be better, be that surgery, or perhaps just sticking with the tablets and not doing the procedure yet, because ultimately we don't think there's that much benefit to be gained. But when we assess the patient, we're really trying to understand whether the symptoms that the patient's experiencing are likely to be caused by the narrow valve. And we just need to be sure that it's the aortic valve that needs treating. We then need to explain to the patient what the procedure involves, and is that there is a risk of death and there is a risk of stroke. But 19 times out of 20, those awful complications won't happen. The intention is not to do a general anaesthetic for most patients, and we call it conscious sedation, so the patient is conscious enough and talking to us, although sometimes we are aware that their memory might not be quite as clear as after the procedure as it might have been because of the medicines we've given. Well, that, to be honest, isn't such a bad thing. You know, this can be quite a scary environment, and perhaps it's best not to remember everything.
I remember lying down there. The next thing I remember was waking up in bed. I don't remember anything whatsoever about the operation itself. I was told that the degree of anaesthetics that to be given may be just on the border between conscious and unconscious, but certainly I was not conscious afterwards.
Before we actually start putting the device in, we put a temporary pacemaker in, we put some cannulas in so that we can give intravenous drugs. We're then going to make 2 incisions in the groin, one for the TAVI device and one tiny one in the groin where we have another catheter so we can actually see what we're doing. So the valve is what we call a sheath, a large plastic hollow tube is put into the artery in the leg, and the device is brought up against the flow of blood round the arch of the aorta into a position just above the heart. We then push the squashed up valve into the heart, into the orifice where the existing valve is. By expanding that, and we do that with a little handle at the other end, but we expand the new valve, and the new valve expands, crushing the old valve, the existing valve behind it. The amazing thing is that once the new valve is there, it immediately starts to work. And so we can, if we need to, we can collapse it again if the position is not right, move it a little bit and do it again. But we can get pretty clear about exactly where it needs to be. If it needs moving up or moving down, we can do that. And that positioning element obviously is terribly important, and it probably takes 4 or 5 minutes. The heart seems to tolerate it amazingly well. The patient doesn't even realise it's happening, to be honest, and that's partly because this valve, once it is almost 2/3 out, it immediately starts to work. And so although we're monitoring the patient's blood pressure, blood pressure rarely falls and the patient barely notices, to be honest, that we're actually at the key point in the operation. And what we often see, pleasingly, is the blood pressure starts to come up because all of a sudden the heart can contract through that valve which is no longer obstructed. And so actually, you could argue that the patient starts to feel better almost immediately.
I was in the recovery room for a short time and then moved up here. Since the operation I haven't had any pain that is resulting from the operation at all. The actual areas in which the incisions were made, only when I press on them, if I press a little on them, that they actually feel painful. Everybody that you're involved with, in fact, seems to, well, it makes us as comfortable as possible.
Patients just spend the next few hours after the TAVI just in the next door room outside the cath lab in our day case unit. And that's really just so they're nearby to us. And often patients are well enough, literally, to have a cup of tea when they leave here. Patients will usually be in hospital 4 or 5 days following the procedure. That's really just to allow the wounds to heal, but also to see whether a permanent pacemaker is necessary. Most people start to feel better after TAVI almost immediately. Obviously, it depends a little bit how bad you were before we put it in. But I think most people feel probably 3 or 4 weeks, the speed of their recovery is starting to taper because ultimately they're starting to get back to good health. So it is quite a quick recovery, really. Usually patients will feel less breathless. Often patients feel as if they've got more energy, but basically trying to reduce chest pain, breathlessness, and that potential for people to black out when they're doing things. So they're the 3 symptoms that we would expect to improve following a TAVI. The idea is to get rid of the symptoms that have stopped you enjoying your life and to get you back to a position where you can do what you want to do during the rest of your retirement. When you leave hospital, there'll be a telephone number you can ring if you've got a problem. We'd like to see patients usually around 8 to 12 weeks for a scan to see how the valve is looking and just to check up on everything. Thereafter, we see people perhaps every 6 months or a year, and we'd like to do that probably for the foreseeable future. And the reason for that, in part, is that this is a relatively new technology. Some of the tests that we do are for benefits to the patients. Some of the tests benefit us because it gives us more information and helps us to evolve the technology so that we can do safer and safer procedures that will last longer and longer. There's a pretty good backup system if there are problems or questions that people have following the procedure. And there'll be plenty of opportunity to ask questions before and after with regard to what you might expect or what might happen. If you have a driving licence before, you need to tell the DVLA that you've had a TAVI procedure, and it usually is about 6 weeks before you can resume driving by yourself.
The TAVI is in fact accepted as an operation by the driving licence authority, so I'm driving again.
I think exercise little and often is what we want. We like people to walk as much as they can. We would like occasionally, if they feel like cycling or occasionally swimming, that would be great. But really little and often exercise is what is the prescription from me.
I think over the last couple of weeks, in fact, things have started to improve much. And certainly now it's improving quite a lot. I can walk right round the town here, up the hill, round the town and back down again and things of that sort. So a couple of miles or so you manage, you appreciate them more and more, that you are feeling better and you can do that. And you can breathe better and you can go up hills and do things for yourself without having to make such a big effort. The change has been very significant.